morning. I am Dr. Kusumita. In the next 5 minutes, I'll be taking you through an interesting case of myotonic dystrophy that came to our OPD. No financial interest disclosed. So, a 42-year-old male patient presented to our OPD with chief complaints of decrease in vision in both eyes, which progressed gradually over 6 months. Along with that, he complained of drooping of both upper eyelids, progressing since last 2 years. On external examination, the patient had severe blepharotosis in both the eyes with MRD1 of 0.5 millimeters. The lid crease was absent, there was no lid lag, and LPS action was 4 millimeters. Further examination showed that there was no diplopia. Cover-uncover test showed orthophoria. Patient had, on ductions and versions, he showed no movements in any gaze in either eye, giving a frozen globe-like picture. FDT showed restrictive pathology. Best corrected vision in both eyes was 6/12. Pupils reacted normally to light and accommodation. Other than bilateral cataract, which was nuclear sclerosis and posterior subcapsular, rest of the anterior segment was normal. Gonioscopy showed open angles in all 4 quadrants. IOP was 18 millimeters mercury. Posterior segment examination showed syncytial scintillance in the right eye. Both eye discs had healthy NRR with a CDR of 0.3, and the rest of the retina was within normal limits. Other than that, he had typical features of myotonic dystrophy. Patient had hatchet face and swan neck, attributed to the wasting of facial and sternocleidomastoid muscles. He had proximal muscle wasting, dysarthria, frontal baldness, which are the classical symptoms described by Hans Steinert, distal myotonia of the thinner muscles, and gait disturbances. He underwent MRI of the brain and orbit to rule out involvement of the gaze pathways. ECG was normal, and blood test gave normal thyroid function tests. Now, looking at the various differential diagnoses, we considered myasthenia gravis, but which was unlikely as there was no fluctuation or fatigability of hystosis or ophthalmoplegia. Thyroid orbitopathy was ruled out as there were no lid signs or exophthalmos. Myositis was excluded due to absence of pain or inflammation. Chronic progressive external ophthalmoplegia are a group of disorders with symmetric bilateral painless progressive pupil sparing ptosis and ophthalmoplegia. However, distal myotonia, wasting of the face and neck muscles are prominently absent. Kearns-Sayre was ruled out because it has an age of onset before 20 years and is associated with pigmentary retinopathy, cardiac conduction abnormalities, and cerebellar ataxia. And oculopharyngeal muscular dystrophy is another CPO-like disease with nuclear DNA mutations, unlike mitochondrial DNA mutations in CPEO, but complete ophthalmoplegia is rare. Myotonic dystrophy, also called as Steinert disease, was described by German physician Hans Gustav Wilhelm Steinert in 1909 as a classic triad of proximal muscle weakness, dysarthria, and frontal baldness. Ophthalmic signs of cataract, which is classically described as Christmas tree cataract, ptosis, and ophthalmoplegia were described later. Its genetic basis was described in 1992 and has some interesting points worth noting. It is autosomal dominant inheritance associated with dystrophia myotonica protein kinase gene in chromosome 19. It is associated with trinucleotide CTG repeats, and the phenotypic expression depends on the number of repeats. So less than 34 repeats may be asymptomatic, whereas more than 50 repeats show full manifestations. It shows the phenomenon of anticipation, which is in the subsequent generation, the disease manifests earlier and with more severity. Myotonic dystrophy is a debilitating multisystem disease with no known cure, with wasting of facial and neck muscles, proximal weakness, and distal myotonia. Involvement of the respiratory system leads to fatal complications. Classic myotonia dystrophy presents in the 3rd to 4th decade, and ophthalmic manifestations are telltale, preclude other symptoms, and provide clue to early diagnosis, and include posterior subcapsular cataract, ophthalmoplegia, ptosis, and the typical phases. Lab confirmation can be done by looking for the CTG repeats.